and arranged now. Hello. I'm starting now with to saying to all of you hello and one warmest welcome you for your to joining us. And I see today some colleagues, dear colleagues, and we have the honor today that we have Professor Christina Stefan with us, who has joined the distinguished faculty of the Global Oncology Implementing Science as a renowned faculty in the world. And before the end, we would like to hear her precious comments as a distinguished faculty and a big thinker, really, in global thinker in oncology. Now we start with the lecture of Professor David Kerr. He is well known, Oxford University professor of cancer medicine and previous president of ESMO and renowned, really global oncology figure, author of many books and many articles, and particularly also in the field of clinical trials in Oxford.
Professor of Cancer Medicine from University of Oxford, and I'm delighted to join this seminar. I invited my dear friend, Professor Ahmed Al-Zawi. We've been collaborating for many years, and many of my friends and colleagues are gathered around this table so that we might discuss in the win-win setting how research might contribute to our overall program of cancer control in low and middle-income countries. This brief talk is a little about clinical trials and how we might provide a framework for medical research. Excuse me for one moment while I work out how to move the slides on. So we know that there are many obstacles to research when one is working in resource-constrained settings. There may be limited central investment in research. We're very lucky in the West and the North that we have well-established medical research councils, significant investment by government across the spectrum of research, physical sciences, medical sciences, and so on. If there's not sufficient central research funding, of course, that implies, or one of the consequences is that there'll be a limited research infrastructure. For example, in the field of clinical trials, unable to get access to ethics review boards, the statistical support to develop protocols, the study staff required to monitor, to deliver the trials, the laboratories, the clinic space that we need to deliver any of the protocols that we feel would be important for the community of patients that we treat. And of course, we know that underpinning a lot of this is a failure, effectively, of cancer registration, proper pathology in terms of tumour reporting, access to imaging to measure the effect of any new treatment regimen, that sort of thing. There are many, many academic issues. Perhaps the most important that we've heard from our colleagues is that lack of protected time for investigators. I'm very lucky as an Oxford University professor. I can split my time for research in the laboratory, in our clinical trials office, and my clinical practice, and both are supported by the hospital and by the university. And that's a model that, again, works very effectively in the North and in the West. But I know that there are real difficulties for our brothers and sisters who are keen to contribute knowledge, who are keen to participate in research, but they just don't have the set-aside time to be able to do this. Failure of tenure, failure of promotion, failure of an academic track, and of course the continual withdrawal of those leaders of tomorrow being taken from their home countries and being absorbed, being rewarded in healthcare systems like mine, the National Health Service in the UK. And of course, if there's no central drive from government, then it means that there's a very limited culture of research, difficult to have mentors, difficult to have people that one looks up to who have strong research portfolios or of strong research standing. And perhaps, again, something that together we're looking to overcome is limited understanding about the importance of cancer amongst clinicians, policymakers, and the general population. The general principles of the approach that we want to take within the Win-Win Consortium is that we would like to strengthen the base of evidence to guide cancer control in public health settings. Ahmed Muir-Gray and I have talked about in the past about better value healthcare and how we can use public health policy to get best buys. We know that WHO, in their very well-written documents to help guide cancer control policy, that we look for best buys or better value delivery of cancer control. We want to validate specific interventions in specific populations. Too many, the vast majority of clinical trials take place in Caucasian populations, well-nourished in relatively rich societies. Can we immediately transfer those data to those of our patients who have a very, very different social and resource setting? We talked earlier about how we can use value, use limited resources effectively, and how can we maintain and strengthen the quality of care. And research has got to be an important element of that, not just into the drugs of tomorrow, but research into how we can best deliver healthcare, cancer care as it is today. How can we promote innovations? Well, we need to build research training capacity regionally. Partnerships are important, north-south, but south-south partnerships as well. The idea about providing central services for clinical research. If there's a bright young researcher in Ghana, for example, how can we help them to develop a conventional protocol? Well, there's a lot of very helpful boilerplate protocols that we've got. We've got access to statistical support and so on, so that that bright young investigator can put his or her idea into a standard format of the sort of protocol that would be accepted and supported by an IRB, by a local research ethics committee. There are many great examples of joint projects, some fantastic examples already existing of programs linking, for example, African and American, European universities. Building successes, what can we learn from those who've done so remarkably well in terms of networks and treating around HIV, malaria, TB, cervical screening network, and so on. And again, an idea that we'll be discussing later, but promoted strongly by Ahmed, by Will, by Twalib, the idea about having e-learning facilities, having an African virtual university that can help support the training and to help guide those young researchers of tomorrow. Why should we develop studies in Africa, taking Africa as an exemplar? Well, being very hard and scientific about it, there are unique population comparisons. People like myself are interested in the genetics of cancer susceptibility, the genetics of how we respond to different drugs, how we can compare germline and somatic tumoral mutations. So a lot of my research in all of those fields would benefit undoubtedly by comparing Caucasian and African populations. We're ancestrally related, but we're quite environmentally distinct. So it allows us to pull apart those two elements that contribute to the development of cancer, different disease patterns and natural history. And I think it's our duty to help build capacity for research in Africa. We've held conferences in the past about how we can support cancer research. And one of the ideas that comes out is the concept of having centres of excellence and perhaps the equivalence of national cancer centres. And if we were to think what skills, what attributes those might have, then this is a sort of diagram that might allow us to pull together that sense of what we think a centre of excellence should be able to do. Protocol-based treatment, patient materials around education, awareness raising, training, probably the central tenet of all that we'll discuss during our symposium around the different aspects of clinical research. How do we provide trial site support to those hospitals and clinicians that would like to support any given clinical trial or protocol? How do we assess a programme? It comes back to peer review and peer audit, something that has stood the test of time. It's not perfect, far, far from it, but at least it does allow a fairly objective view as to, with limited resources, what protocols, what research areas we should or should not support. And as was said repeatedly, we should move to an e-health system. We can deliver much of our clinical trial work using data collection forms that could be delivered in mobile phones. So we need to be thoughtful. We need to move away from paper. We need to reduce bureaucracy. We need to focus on collecting data that's absolutely key. This is a point for young trialists, don't cram too much into your protocols. Keep them as simple, as clean, as clear as possible, focusing on the primary objective. Reduce the number of secondary objectives, because the more data you try to collect, the more likely you are to fail. So focus, 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 and would be a strong take-home message. What are the benefits for us developing international trials networks? As we said earlier, linking the United States, Europe, and colleagues in low and middle income countries. The more patients available, the greater the speed of recruitment. If we were a pharma company, multinational recruitment improves the quality of the regulatory package that would be sent to governments for consideration of drug registration, commercialization, and so on. Potentially, it could lower costs, and that shouldn't be the dominant driver, but it's something that may play a factor in deciding which countries, which centres one would place a multinational trial. And as I mentioned earlier on, with the right sorts of numbers, it does allow us to start exploring how different ethnic populations respond to drugs in different ways. And is there an underpinning genetic reason for this? Something that we find particularly fascinating. I think implementation science is an area which has been long underutilized. People like me, our focus is on cutting bleeding edge science and publishing in Nature and New England Journal of Medicine, Lancet, all those sort of top journals. And it's expected. The university you can see behind me is one of the top, if not the top, medical school in the world. It's an incredibly competitive environment with some fantastically intelligent people. And I benefit from being in an environment of that sort. An expectation from us is that we will be leading the research of tomorrow. But if I complete my clinical trial, I publish it in the Lancet, what's the delay? Does my job finish then? Or should I be doing more to take any clinical trial findings which are perhaps practice changing? How do we go from publication in the Lancet to widespread adoption, uptake of whatever the practice changing clinical results are? People don't pay enough attention to this, and the gap between me publishing the Lancet and, for example, a new treatment being rolled out across the NHS can be 5 to 10 years. Absolutely ridiculous. So think about implementation science as being genuinely an engine that can accelerate progress in global health. And this is looking at factors which, as I just mentioned, influence uptake, adaptation, adoption of evidence-based health interventions. I think this is an area in which low and middle income countries could play an enormous role, looking at knowledge translation, transfer and exchange, research utilization, implementation, dissemination and diffusion. Could this be a new area of strength? Because certainly it's an area of relative weakness in the north, in the resource-rich countries. Is this something that the thought, the intellectual underpinning, much could be made of it with our fantastic colleagues in Africa? So this has been, I hope, a talk which is provocative. It's not seeking to give answers, but offering many questions, some potential solutions, but an idea above all that we should work together. I think partnership models to establish clinical trials, infrastructure training, of course, with a planned transition to independent clinical trials groups, I think would be important and welcome. And we have some fantastic resources in the United Kingdom, across our National Health Service, in terms of training and establishing the backbone of how we would deliver a clinical trials office. There needs to be a strong intellectual base to encourage this research activity. Again, the power of partnership can help support those fantastic young researchers who feel they've got to pursue their career outside of their home country because there's no academic track, there's no potential tenure, and we need to create the space, the time, the funding, so that those careers can be fulfilled naturally at home rather than always being elsewhere. And I have no doubt that we won't expect governments to solve this on their own. They're key partners, but we need to bring in external academia, and I would hope industry would have a role to play in terms of how we integrate and pull together. So I think we're standing at the point of a fantastic opportunity. It's something that we're very keen to help support. I can say that from my colleagues behind me in Oxford, with the expertise that we have here, and look forward to seeing how we can partner and work further. But thanks very much indeed for listening. And I do hope we have a chance to discuss this further during any panel discussions that we have later. Many thanks indeed. Thank you.
I want to address the pain point while we sit here. Not only on the user side, we heard about all the things lacking in Africa, India, Pakistan, etc. I want to turn it around. I want to make it something possible for those oncologists on the ground seeing patients, and how we can improve their lives, not the patient lives indirectly, their lives. Because what are they facing? As an oncologist, you see a patient with a problem, which is cancer. And what you do is you dig into literature and your own knowledge to know what drugs or treatments are there, proven to be efficacious. So you go into the guidelines, you go into PubMed, and you find the drug or the combination radiation of surgery, which has been proven, but it has been proven in clinical trials done mainly 90% in the Western world, right? They're not done on your regional population. As well as they're performed 90% in early stage cancer. They're not performed in that advanced suffering patient you have in front of you. So more than 70% of clinical trials are aiming stage 1-2 disease. Okay, so it's difficult to find knowledge or guidelines of advanced, local regional advanced breast cancer patient. Okay, so you already have little knowledge, written knowledge and guidelines on your back to make a medical decision. So what are you going to offer? Every oncologist, at that moment you make the trade-off, you're not only looking what will be the response rate, but you also have to trade off the costs. The cost, what that drug will mean financially, or do you have that radiation department behind you or not? The availability and the cost of that financially and logistic, but as well as the means for the patient, the risk you're going to take. Because if every treatment has side effects, we cannot forget that, and we make that mental calculation every time you have the family and the patient in front of you. That knowledge of side effects is also based on clinical trials, what we are reading in journals and what we find in PubMed. Toxicity equals between 5 fractions and 30 fractions, or this drug is safe, okay? Those regimens are tested in a populations who are far more fit and younger than you see in general in front of you. We know that patients treated in clinical trials, just by being treated in a clinical trial, lives 30% better than those outside trials, okay? So you are not sure about your knowledge, what you're going to give in terms of efficiency, and you're not sure what you're going to cost. Okay, and I think that is a pain point I want to tackle in the Western world, because that trade-off is everywhere equal. However, toxicity in the Western world today gets relative, right? We can be so precise, as we say, or we can be so monitoring well that we can tackle that quite good. When you are outside the Western world, you lose your patient too easily, far away, 4 kilometers away, and they are having more advanced disease and they are far more fragile, okay? So I'm still in my first slide, okay? But this is the backup. What is reality today is that we see less cancer still in the non-Western world, but when you look at the mortality, the ratio, how deadly the disease is shocking. Every time I show this is man, and we talk about gender relation, women are as bad, right? That mortality is not only cancer mortality, it's also mortality because of treatment. And we should not forget that, okay? So when you're going to prescribe chemotherapy, there is a risk, a reality that you will kill the immune system of that patient. And that means that HIV or a stupid common cold can take over and become mortal in that patient, okay? What we do in clinical practice is we see a patient, we try to make it as compliant as possible, so to really motivate, to say, okay, I'm going to do something with you, but you have to help me. You have to comply, you have to come back. And every time you feel not sure, ring me, okay? So you work on your emotional but binding all capacities to create compliance. Okay? You're going to educate, and you try to find tools to monitor what you're doing. The moment you prescribe, what are your trade-offs? You want to know how they have been treated before, how fragile they are, how old they are, what kind of disease they have, and what are other diseases are in there as well. Okay, so there are in every country the same risk factors. We know if you do a 5FU treatment in the Netherlands, Amsterdam, or in Cape Town, it's the same drug, and you think you make that mental counting the same way. However, the background is not the same. Maybe tumor pathology is not the same. Genetics of the patients you are treating are not the same. We know that there are certain genetic profiles who are far more sensitive to toxicity than others. They cannot eliminate the 5FU, 10% of the patients, or they really react badly on radiation. That's all about 1%. Okay? For today, We do a 5 phases questionnaire, we look at the blood counts, we go and we cross our fingers, right? That's reality. Today, with our communications and data collection tool, I think we can do far better. So and there I come to my project, where I would like to have your interest. Because what I want to do is to collect data of your populations and to see what is prescribed, okay, and what happens after. Because if you come in the title, if you want to predict outcome in terms of toxicity risk as well as efficiency chance, you have to have large groups and come to a conclusion. And I'm talking now not about randomized trial settings, I'm talking about real population data, which is region dependent, okay? This is a whole industry which is already going on because we have far better data collection materials, cloud, whatever, going there now, possible to do this. Okay? But what happens is, it happens in the Western world. So whenever I come with a tool, will not be applicable for where you are. Okay? The algorithm is not the biggest problem. How to predict, if you have the data, the algorithm I have already. I have the team to do that. Okay? What I need is the data collection and test that. The test, what is tested in the Western world, to test also in India or in Cape Town or other regions. Okay? How does it work in practice for a physician? And now we really need to catch up with Chapsnot, whatever, Facebook. I'm even the wrong generation here. But we have to catch up there because those patients and physicians, what they have their mobile phone. Okay, they're going to use that. They're going to use that to do the education, the monitoring, and the questionnaires, and to make them also communicate among each other. Because that we spoke about the mental and all the cultural difficulties around cancer in your regions, that comes aside. We have to work on that compliance part because data and just giving will not result. We need to know what happens after.
Hello. Welcome all. Today is our 5th session of the Global Oncology Implementing Science GOIS program of the Global Oncology University, GOU. The title today is Close the Cancer Divide. As you hear, all of the disparities, the cancer divide, equality, but in our approach, we think about realization of how to solve via evidence and implementing science and win scenario in the real world. This is truly on behalf of all leaders and faculty of the Win-Win Initiative. Disclosure of conflicts, nothing, no. Notice that the most of our slides, the text is not short. With few words or something, no, because we are very keen that some of these slides could be useful as a PDF text if you would like to receive these slides, and also we add some references to be more useful if you search about more evidence and more published data about what we are discussing together. This lecture is based on the London Global Cancer Week. Last week, it was done last week, about Cancer Moonshot, win-win collaboration to close the cancer divide. And but this based on this presentation, but with some additions and updates and some also references. Short brainstorming question and notes. As you know, the Win-Win movement aims at the increase of better value cancer care for millions of underserved cancer patients in the world in rich countries and low middle income countries via scientific approaches and within win-win scenarios. Okay, this is our objective and goal together. But is that feasible? Is that realizable in the real world? Yes, Are there already published scientific serious examples to reduce the enormously the cost of cancer care without compromising the outcome? Yes, yes, yes. Could you tell us some example? There are many. There are tens of published examples. Consult our book and refer literature, and we say some of these examples. There are many. I don't know why all pass by it or miss it. There are many examples, published examples. Along the last 2 decades and even 3 decades, there are many conferences, publication, commissions, agendas, declaration about to address the big problems of access to cancer care. But what was the outcome? In fact, the gap between the required cancer care and the available was widened in the last 2 decades. This is published by many authors. And there is no convincing evidence that the needs wouldn't be increased in the third decade of the 21st centuries. Is a problem of low-middle income countries only, or it is global and also is in rich middle income countries, with variability of the problem, the variability of the magnitude and cause and many things. But according, we can see here that according to American Society of Clinical Oncology, ASCO, 40% of cancer patients, of citizens, citizens in the United States, the first cause of fear of cancer is its financial burden and the risk of bankruptcy. You see here example, we see it here. In the USA also, the median launch price of 13 new cancer drugs introduced in 2022 was $77,000, which is more than 3 times the median household income of California family. You imagine this. So what's about this is the rich state in the United States? So what is about no-middle income countries in many parts of the world? There are reference here, and there are a nice article in the Medscape here, and there's a reference. And see, please, my comments on this article is published also on the website. It is my comment was: is in time to create smart global win-win deals based on scientific approaches to increase affordability of better value cancer care in the world, provided that no one would lose and the winner will gain more. In European Society of Radiation Oncology, the 1/4 of studies, there are you find that surprisingly, 1/4 of cancer patients in Europe didn't get their indicated radiotherapy. You can imagine what's the case in low-middle income countries and sub-Saharan countries and other. This in Europe. Is the question of proposing global cancer fund or similar proposal is the key of solution. It helps, but it's not the magic solutions, because whatever the amount of the global fund or at the global, the local level, the richness of a country or what the richness of any country, if value-based cancer care, or better to say triple value care, that includes among many scientific is not used to reduce to the West and to reduce the West, then we see that it will be like trying to fill a tank while there are big holes at the bottom. We should search for better value, resource saving, and decrease the waste. Could we show some examples of published example? Yes, there are many published examples. One of the shocking examples is to how to reduce the cost of the treatment of certain drugs from 100,000 US dollar to be only $4,000 or $6,000 without compromising the outcome. It's published, okay? All these are reference, okay? In some other drug, to reduce the cost of scientific way by 70 or 80%. There's many examples, like for example, the abiraterone, lapitanib, and other things. You find here even exaggerated, provocative articles here by Ratan. It's called "Flushing Oncology Drugs Drawn Down the Toilet." Provocative, huh? Read it, because there are many other examples. released by distinguished authors and published in respectable journals. Moreover, there are many misleading things about immunotherapy and about new cancer drugs and clinical trial, particularly phase 1 trials. So it could be optimized on scientific basis, and mostly the cost will be reduced, and all without compromising the outcome, and even in some cases to get better outcome on patient health. There are even here Rattan and Lichter, and there are some other articles empowering the FDA to require dose optimization of the new oncology drugs. There are many things to be optimized and to be corrected in trials. Could give us some of the shocking example of the West. Yes, I give you one example, very shocking, that the West of leftover on bias of some expensive cancer drugs is $3 billion per year. Only in USA and only by 1 year. There's many publications here. This is also only a calls for or complaint of the West, but with no solution. But there is no solution. No, there are solutions unpublished to reduce enormous disease waste. Yes, but who listen? Instead of really talk about shortage of radiotherapy in Africa and some part of the world, it's possible to treat the double or triple number of patients with the existing present facilities now in many countries. Yes. There are many publications here. Please consult here the chapter Science and Affordability of Cancer Drugs and Radiotherapy in the World, Win-Win Scenarios. It's a chapter in book Advances in Cancer Management. There are a publication by Niloy Data, Sinha Data, and Masoud Sami. There are many other wonderful publications based on experience and science. For that last point to be in the real world is that will decrease upcoming plans for expansion on sales and manufacturers for radiotherapy device, or industry will be angry. No, it will be most effective way to open weak markets or even dead markets for the needed 10 to 12,000 radiotherapy of clinical oncology service in the world. Is the problem of resources or limited resources in Africa or other parts of the world, South Asia and Latin America and other parts? No, I give you the example of the most tragic situation that's stated always about the limited resources in Africa. No, it is a myth. Africa has the curse of having rich resources. That is why it was colonized. Is the solutions to send some funds or begging or charity from rich country to Africa, other low middle income countries? No. But it should be well scientifically planned, transparent, win-win approaches. Every US dollar should have its positive return on both taxpayers and in rich countries and citizens in low middle income country. And there will be enormous scientific progress as well. Is cancer is a modern problem of the last centuries, for example, as some rumors about this? No. In simple words, cancer is related to division, proliferation, and mutation of cells, and started with the first multicellular creature millions of years before the first mammals, and surely before the first human beings. What about the title raised to finish cancer to be zero in the world, including low middle income countries? There are many titles like this, to be scientific. Fortunately, cure, survival, and quality of life are improving remarkably. Cancer earlier diagnosis, detection, prevention are increasing. So every collaboration effort should paid for it. So, but talks about zero cancer are still TV talks, political slogan or organization slogans. But focused scientific works, exploration, and win-win collaboration could lead to enormous innovation and unprecedented progress in cancer care and control in the world. This is the goal. it is not romantic talk. No one would lose, because no one would lose. The present winner will gain more and not less. The present underserved will get the requirement with dignity in the real world. But if we continue as we are, the crisis will increase for all, the rich and the poor, industry, all stakeholders. What do you think? Isn't it time to go to be together as independent, respect the entirety of any, no problem, but coordinated efforts as well as stakeholders, including organizations, institutes, industries, business, companies, and governments and individuals in global win campaign based on scientific realizable approach? I leave the answer for you all. Finally, the only hope to success of this scientific initiative is to be adopted, improved, implanted, and implemented, and led by many of you. The notion of win-win is not competing or replacing any, but a forum that belongs to all. If you'd like to PDF of these slides, please send to us at this website. And thank you, and warmest welcome to you, and looking to hear from you all. We are open for all. This is yours. This is your initiative, and this is your its success depends on all of you. And please forward these slides, forward this presentation, follow this video to all your colleagues and interested. Welcome all. Thank you all. I am glad that we have with us today Professor Christina Stefan. I see also Viviane. We count on Viviane a lot for promoting for this important initiative. I see Professor Luca Incroci. I see many other colleagues. So let us start with Professor Christina Stefan. And we are waiting for your, we are looking for your precious advice and leadership. Welcome, Christina.
Thank you so much, Professor Ahmed. We have been friends for quite a number of years, and I really feel extremely honored to be able to come and give some, let's say, reflections. This is definitely not a lecture. Because I haven't seen really all the PowerPoint presentation, but I did listen carefully to everything that has been presented, and I would like to really contribute with some thoughts. So number one would be, despite the fact that it's rather condensed and, you know, during only 1 hour, you try to cover many subjects, I think it's really a matter of reflection to the participants to go back and sit and read and think about everything that has been said, because it's a lot of wisdom and also a lot of knowledge and experience of people who have been in the field for so many years. I would start saying that when I started global oncology, so I'm a South African, I consider myself a South African clinician, someone who practiced in Africa for many years. So when we started, global oncology didn't really exist. Or not that it didn't exist, it existed, but did not have that name of global oncology. Because what we were doing was actually global oncology, trying to work together with other colleagues, instituting, you know, programs such as twinning, initially with high-income countries, then between ourselves, like we introduced twinning between 2 African countries like Namibia and South Africa. We try to share our experiences, and this is how, you know, for so many years we practice global oncology. And even if we still do not agree on a common definition, because if I asked quite a number of colleagues what is global oncology, many gave different answers. Some of them talked about research, some of them talked about teaching, some of them talked about implementation. Absolutely all true. So even if we don't agree on a common definition, we have the same understanding. And we definitely agree on, let's say, 2 or 3 essential items, on which one is the mutual understanding as Ahmed will call it, win-win. So mutual understanding. Secondly, the need for funding, but not as a solution. And I would say thirdly, and perhaps the most important, is the collaboration. So I think it was an exciting session. I enjoyed especially the question or rhetoric question, should we have a global fund for oncology? And I remember that a few years back, we had a meeting in Switzerland where we really approached this discussion and people would compare. Why not? Because that has been done on HIV. But HIV is not the same as cancer. HIV is one disease. Cancer is not just one disease because it includes so many diseases. And the global funding is definitely not a response or not a solution to our problem. And again, it has not been mentioned because I assume every single one of us knows that currently the percentage or the number of clinical trials in low mid-income countries, and especially in Africa, is so much lower than in high-income countries. So if you look at the last 2-3 articles, really maybe we cover, I can't remember, 20% or even less than what it is covered. While our population, if you look at the estimates, 1 in 4, 1 in 5, 1 in 4 actually will be African. And we still adapt clinical trials, or we still adapt protocols from United States or from Europe. And then at times we are surprised why our patients are not responding or are not responding the way of how the other patients are achieving, let's say, remission, or the outcome is so much better. And I need to draw your attention perhaps on one of the success stories, again, started in South Africa with HIV, when, obviously we had so much more experience in HIV and patients with cancer, and particularly in children with cancer and HIV. And we proved to the entire world that what has been published at United States, the types of cancer and the type of treatment that was given was actually completely different than what was happening in Africa. So I believe that the contribution of the African research and the African clinicians was absolutely essential. So, of course, I mean, nobody talks now about incidence or prevalence because all we know about the tremendous burden in low-income countries or in Africa. But what I would really like to say, that cancer is not a problem just of the high-income countries, is not just a high-income country problem, but just as much of low-mid-income countries problem, because cancer does not know boundaries, and we all know that. So I'm ending asking you to reflect on 2 issues, which are very close to my heart. And one is related to equity. What is global oncology, or equity in global oncology? And of course, we can talk about hours, but I would really like to ask you to think about that. And again, about innovation. And instead, perhaps we talk a lot about building up capacity and about data sharing. But from my point of view, perhaps I have a different perspective after 30 years of practicing in Africa. Why would one give the data or share the data instead of really building or bringing the expertise of AI or ML and doing the algorithms locally in Africa, and really trying to, build up the capacity of new bioinformatician, computational biologists, using all the resources that we have there. So I would suggest perhaps a new definition of partnership, or a new model of partnership. And again, looking in terms of, as Ahmed was saying, zero cancer, I think, let's say it's not a joke, but it's not something real. I think we really need to live with our feet on the ground and be realistic and go step by step and have, a time frame. And then I'm sure that us as Africans, we have a lot to share. We have a lot of knowledge that we could also, help the others. And I'm thinking, one last example, when we talk about clinical trials, so when we talk about protocols, in Rwanda, where there is an Institute of Global Health Equity Research, we created a new clinical trial unit, and we talked about manufacturing. So new drugs being manufactured on our continent in Africa. And we talked about innovative ways in which we do repurposing of drugs. So why can't we be those that we would, really drive all these innovations, because we are capable of doing that. So yes, there are challenges, but I think there are plenty of opportunities. And I truly believe that our time is now. And I'm looking forward to connect with the other participants. And if anyone is interested to continue the discussion, please feel free to reach out to me, and let's join together the forces. And congratulations for a successful session, Professor Ahmed.
Thank you very much. Uh, Thank you very much, dearest Christina. And this is a good occasion to ask you kindly not only to join as one of the leader of the program in general, but what you presented today deserve really at least 2 or 3 lectures to and discussion and panel discussion after, because there is many important point, many practical point. And I leave for you also to arrange this panel and to invite a speaker to be more broadly and more widely discussed. So if you accept this, it will be very kind of you. Okay. And be with us together. Always, Christina. Now, I would like to hear from Professor Luca Incrucci, if he is still there. Luca? Here. If you hear me, please unmute your mic. If there's technical problem or something, please now, Vivian.
Are you trying to unmute me?
Please, yes. Yes. Hello, Vivian.
Hi, hello, Professor Ahmed.
I would like to, I know you very well, but I would like that you introduce yourself and how the media and your role in this program is extremely important, and we count on you in promoting for this program. This is just a start. We should not be impatient, but should be very patient. And this is we have a message to spread in the world, and to be adopted by all. It is not my message and your message, but the message by all. So I would like to hear from you, and we will be so pleased to be always together and your effort with you. We deeply need you. Please.
Oh my goodness, I wasn't expecting to say anything, but once you ask, like a true soldier for global health, I will. But anyway, yeah, so I am Vivian Kopsinger-Birchall, and I'm very always excited to be in a space where I'm learning about what is going on in the science space, in the medical space, and translating that into easy communication with the rest of the public, because like you always say, we all have a role to play. Some of us are clinicians, researchers, pharmaceutical company leaders, but and then the general public, because we can be advocates, we can create agency as people who are affected by disease one way or the other. So I'm really just humbled to be in the space where a lot of people are doing, like yourself, and everyone on this platform is doing great to really bridge these disparities. And the previous speaker spoke about AI. You know, as we're talking about, AI is also a form of communication right now. And what I just wanted to emphasize, like what she said, that it's, I think, important and critical for these models to be trained in the environment in which they're going to work, so that we avoid biases that are going to hurt people. So anyway, that's briefly what I do. I just sit in, listen, and whenever possible, you know, host people, or host all of you stakeholders on a show, just to talk about your experiences, some ideas of intervention, but also where possible, you know, share these stories in different platforms. I'm also a student at Harvard Medical School, studying Master of Science in Media, Medicine, and Health. So that is going to give me, hopefully, you know, the added tools that I need to really continue this into this space of healthcare-related communication. Thank you for the opportunity to speak.
Thank you very much, Viviane. And we count much on you. And we'll inform you regularly of everything. So we need to spread the message really. And because what is important is not just lectures or webinars, but what is more important is that the message be spread to many people, many all stakeholders, and to be adopted by many researchers, scientists, and the different concerned parties. So they themselves could develop more ideas. And but what we present, as you see, we present that there are already many scientific examples to improve enormously the present condition. So there will be a very open way for the future. And please all, if you need any of the slides that I presented, send to me. We'll send it to as PDF. Also, this is not just lecture and goodbye. All the previous lecture will be accessible on our websites, so the message will be present forever, as I say. So you please spread and forward these videos and lecture to all, and welcome all. And please, all of you, feel that this is your initiative. This is not mine and our colleagues, the leaders, directors, but it belongs to all of you. Is there any question now? Please don't hesitate to even not if it's not leave, just send to us an emails, and we can forward even to if they need some experts from here and there in the world. No problem. There are many colleagues who are volunteer in this work, eminent professor from everywhere in the world. Okay. I okay. Manar. Okay, thank you, Manar. And please, and thank you for your contribution also in two of the upcoming lectures. Okay for now. And next Wednesday at 4 p.m. Greenwich time, and we will have many other hot topics, and we'll go forward after for some medical things and some how to reduce cost of chemotherapy, radiotherapy, how to be affordable, and we'll go to many other details. Thank you all, and bye-bye until next week. Going forward hand in hand. Bye-bye.